Good morning, everyone. Thanks so much for joining us. We'll give it a couple of minutes. We did say we'd start at 7:30, and we know it's early, so we'll give a couple of minutes for a few others to join, but do want to say thank you so much for coming and joining us this early on a Friday morning. Um, maybe while we wait, I'll go through a couple of little housekeeping items. At the top of your toolbar, we have the Q&A section. If you have any questions, and you can put it in the Q&A, Caitlin will be monitoring that, and we will make sure we address any questions. If there's anything we cannot get to, we will follow up and send a follow-up package with the answers to any outstanding questions. And we'll start the presentation shortly, but in the meantime, I am going to just do some quick introductions. So we're very happy to have you here today, and as we do a webinar for HPV implementation and sharing some follow-up information with you all since the launch of HPV testing in March. My name is Sarah Ashton. I'm the regional manager for the cancer screening and prevention team, as well as the Indigenous Cancer Program. And I'm very pleased to introduce our presenters this morning, Dr. Rebecca Ray and Dr. Julie Francis. Dr. Ray is our primary care lead for the Central East Regional Cancer Program. She has a busy family practice in Port Perry and is also a community palliative care physician, attending to patients in their home as well as at Oak Ridges Hospice. She provides primary care to Indigenous patients at the Mississaugas of Scugog Island First Nation Health Center, and she sits on numerous boards and committees and is the primary care co-lead for the Durham OHT. She is passionate about health promotion and works tirelessly to improve the delivery of primary care services in the community. And I'm also very pleased to introduce Dr. Julie Francis as our very new, just within the last month, regional colposcopy and cervical screening lead for the Central East Regional Cancer Program. Dr. Francis is the division head for gynecologic oncology at Lakeridge Health since 2018, and she combines clinical leadership with a deep commitment to innovation in cervical cancer screening. With a focus on compassionate, patient-centered care, Dr. Francis is dedicated to improving how we detect and manage cervical disease. Her research explores new and creative approaches to screening, aiming to make care more effective, equitable, and accessible. So thank you both for being here this morning. Just give me a quick second and I'll pull up the screens, and then I will hand it over, I believe, to Dr. Becky Ray. Well, first, I'll just share this introductory picture of Dr. Francis. So thanks again and welcome to our team.
Perfect. Thank you so much, Sarah. We're very excited to have, I'm so excited to have Julie joining the team. And guys, we've got some exciting things in store to help improve cervical screening rates across our Central East region. So please stay tuned. Please keep coming to these webinars so that we can share out this information. Dr. Francis has done this work already in Kingston and has some pretty cool and super fun, actually, ways to improve screening. So stay tuned for that. One of the programs that we offer through the Central East region is the cervical screening competency training. So our next competency workshop is on Monday. This is at Lakeridge Health Whitby site, and there is still room to register. So the intent of this workshop really is to expand the number of healthcare providers that are trained to provide cervical screening. So enhancing scope of providers. So this training is appropriate for any healthcare providers really who are able to provide cervical screening within their scope of practice. We commonly see nurses and midwives attending this screening, also physician assistants, and any physicians who really don't feel comfortable are invited to come. But this is a great program. If you're interested, so it's on Monday from 8:30 until 1. If you're interested, just shoot Caitlin an email and we will get you the information and get you registered for that. So without further ado, we will get to the meat of the agenda today. So first thing I wanted to do was just very briefly go through the guideline again, just to refresh everybody's memory. So Effective March the 3rd, the Ontario Cervical Screening Program transitioned to HPV screening as the primary screen, with reflex cell cytology and HPV genotyping for those patients who are HPV positive. So the process is the patient comes in, you'll collect the sample of cells at the cervix. The sample is collected in the same way, using the broom and putting it into the thin prep medium. So no more using the blue topped sample containers, but now we're using all thin prep medium. That goes to the lab, and the very first test that is run is HPV testing. For patients who are HPV negative, they're considered average risk for developing cervical cancer, and their recommendation is to repeat the screen in 5 years or 3 years if they're immune compromised. For patients who are HPV positive, what will happen at the lab, you don't have to be worried about this as a provider at a clinical level, but at the lab will reflexively order the genotyping on the HPV to triage into HPV positive of a high risk type. HPV 6, the highest risk type, 16, 18, 45, or HPV positive other high risk types. Okay. So your report from a patient who's HPV positive will indicate they're HPV positive. It'll indicate if they're positive for 16, 18, 45, which means they're triaged directly to colposcopy, or they're positive for another high risk type. And it might just say on your report, patient is positive for other high risk types. It won't actually say which type if they're other high risk. And if they're other high risk, anyone who's HPV positive will actually have cell cytology done. For those who are positive for 16, 18, 45, direct to colposcopy. For those who are positive for other high risk type, we look at the cell cytology. If they have high grade cell cytology, they're going to colposcopy. And if they have normal or low grade cytology, we're repeating their test in 2 years. Okay. On your lab reports that come back to you, it's actually it does get cheat sheet. It tells you at the bottom what to do, but it's important to understand really what we're doing and why we're doing it. The one pearl that I would say, the takeaway message from here is trying not to miss the atypical cells cannot exclude high grade, and L-cell cannot exclude high grade. So they'll be reported as L-cell-H or ASCUS-H. Those are the easiest ones to miss. So those aren't considered low grade. Those are actually considered high grade cytology. So people who have L-cell cannot exclude high grade, or ASCUS cannot exclude high grade, those patients need to go to colposcopy. The instructions will be on the sheet, but I always like to highlight that because I would say those are the most likely sort of missed cases. They're often, our eyes just go to L-cell or ASCUS and assume it's low grade. So just keeping a watch out for that. So then when you have your patient who had HPV positive, other high risk type with normal or low grade cytology, repeat the test in 2 years. If it's HPV negative, now they're going back into that average risk screening. So their next screen is in 5 years. If they're HPV positive on their 2-year repeat, you're going to refer them to cytology regardless, or to colposcopy regardless of their cytology report. Okay. Seems complicated, but it's actually simpler for us as primary care providers than the old system, because there's really less of that remembering. Are they at 1 year? When do they need these repeats? The repeats are really they're in 2 years or they're in 5 years. And if they're still HPV positive in 2 years, they go to colposcopy. And then Dr. Francis will talk to us about what to do when they come back to us from colposcopy as we move through the agenda today. So this helps us to highlight what is the actual risk? So why are we doing a repeat screen in 5 years? So when we consider a patient average risk, so this is the patient that you do their screen and they're HPV negative, their average risk, meaning that their risk is somewhere between 0.12% and 0.4% of developing HPV in the next proceeding to a cervical cancer or precancer in the next 5 years. So the risk of cervical cancer or precancer in the next 5 years for someone who's HPV negative today is incredibly low. It's that, about 0.2, 0.3%. And actually that 5-year risk in many studies is extended out to 7 years. So that's why this repeat screen is in 5 years, because they have an incredibly low risk if you're HPV negative of progressing to cervical cancer or precancer. Immunocompromised patients were the reason the recommendation is for a repeat screen in 3 years is because it's difficult to predict that risk because it depends on what degree of immunocompromise that they have, and their immune systems in immunocompromised patients tend to be quite unpredictable and variable. So the recommendation is a repeat screening every 3 years for our patients who are immunocompromised, even if they're HPV negative. So HPV negative, you're just going to keep screening them every 3 years, the immunocompromised patients. Okay. The moderate risk patients. So moderate risk patients are these patients who are HPV positive with another high risk type with normal or low grade cytology. Their risk of progressing to cervical cancer or precancer is between 1.3 and 3.7% in the next 5 years. So the recommendation is to rescreen in 2 years. So they're at a little bit higher risk. So we want to screen them more frequently. So that's why we repeat that screen in 2 years. And then if they're HPV negative at that, they go back into that average risk category, that green category for 5 years. And if they're HPV positive, they're one of these people who is having difficulty clearing their HPV, right? So they've got an HPV strain that's resistant to clearing, and that's why we then refer them to colposcopy because they've already proven themselves to be a patient who is less likely to clear that strain, and that could be for a variety of reasons. We send them to colposcopy so that they can be managed. And then those with elevated risks, so those who are HPV positive with a high risk type, with the highest risk type, 16, 18, 45, or with another type, but with high-grade cytology, they actually have a greater than 6% immediate risk of progressing to cervical cancer or precancer, and that's why we're referring them direct to colposcopy. So their risk is higher than 6% immediately of progressing to cervical cancer or precancer, so they're going directly to colposcopy. So what we're going to go through today is a couple of the things, like I just wanted to go through that basic guideline so that everyone's up to date on that. But now we're going to go through like some of the things that are happening in primary care, like what do we do with these results to help you guys manage that in primary care. So if you get a report back that says the HPV test results were invalid, this has actually only happened in 14. So early April, we got a report from Cancer Care Ontario, and the first week of April, we had performed 42,697 cervical screens, and 93% of those were HPV negative, and only 14 tests came back with invalid results. So this is a very uncommon thing to happen, so 14 out of 42,000. But if it happens, the recommendation is to bring the patient back into your office for a repeat test as soon as you can, but ideally within the next 3 months. So we don't want you to book them 3 months from now. It's actually as soon as you can, but a maximum amount of time of 3 months. The same as if they're HPV positive, but the cell cytology results are unsatisfactory. We want you to bring the patient in for a repeat test as soon as you can, but no longer than 3 months from now. Okay. If you have 2 unsatisfactory cytology results. So if you recall the patient, you repeat their cell cytology, and you're still getting an unsatisfactory cell cytology, you're going to refer them directly to colposcopy. And then if you get So if you have a patient who had an HPV test that's positive for the highest risk type, it's positive for 16, 18, 45, and the cytology is unsatisfactory, you could actually refer that patient directly to colposcopy. That patient needs to be referred directly to colposcopy anyway. So rather than delaying the referral to colposcopy by having them come in, do a repeat test in your office, and then referring, just send those patients along to colposcopy because they're going to have a cell cytology performed at the site of the colposcopy. Okay, so invalid HPV tests, they need to just be repeated. HPV positive with unsatisfactory cytology, if they're positive for the highest risk type, 16, 18, 45, send them straight to colpo, but otherwise bring them in for a repeat cytology test. And then if you've had an unsatisfactory cytology result in a patient who's using androgen therapy, like for gender transition, or in a postmenopausal woman, you can actually offer them some intravaginal estrogen therapy in the interim, but before you repeat their cell cytology. I haven't done this. I haven't had any actually unsatisfactory cytology results. I haven't done this myself, but this is one of the techniques that certainly the colposcopists might use if there's repetitive unsatisfactory cytology results. I mean, I think probably just bringing them back in and repeating it at first, and then if you get a second unsatisfactory, you're going to refer them to colposcopy anyway, and it might be a strategy used by our specialists. This is just the slide reflecting the immunocompromised population. So just a reminder, this information is on every single requisition for the Ontario Cervical Screening Program. Okay, so if you're not sure, which, I mean, you know, it's hard to keep all of these in your head, you certainly can refer to your OCSP requisition, and there's a little box in the bottom right-hand corner that itemizes the immunocompromised populations. And remember, they're screened every 3 years. Okay. So what about patients who are outside of the cervical screening program? So on an interim basis, so patients who are refugees in this country and are covered by the interim federal health program for their medical care, because they don't have OHIP, because they're covered by the interim federal health program, they're not included in the Ontario Cervical Screening Program. It doesn't mean they're not eligible for screening, but they're not going to be part of the OCSP, okay? So these patients are still eligible for funded screening, but what we're using is on an interim basis until Cancer Care Ontario comes up with a more robust system, we're using the non-OCSP forms for these patients. Okay, so they're eligible for screening, but you have to use the non-OCSP form. And then for Life Labs and Dynacare, using the same processes you would use previously, like in the old system. So it's the same form essentially. Similarly, for if uninsured patients, so if you have a patient, this came up when I was doing a presentation in Peterborough, they have a big student population, an international student population. Students, remember, over age 25 might be eligible for screening, but don't have OHIP funding, right? Because they're international students. So you'll use this form. This is for cervical cytology outside of the Ontario Cervical Screening Program because they don't have OHIP, they're outside of the screening program. So it'll be a patient pay. And actually in the fine print at the very bottom of that section, there's a little comment that says, I acknowledge that I've informed the patient that this is a private pay test, okay? So this is the form that you'll use for patients outside of the Ontario Cervical Screening Program. Cessation criteria. So what has changed? So one of the things that's changed is we're now screening it. So just before we do cessation, we're starting at age 25 for anyone who's ever been sexually active. And then when do we end screening? So patients who have been screened regularly, patients can stop screening. So I'm going to actually cover the middle one here. So when do we normally stop screening? Patients can discontinue screening if they've had a negative HPV test between the ages of 65 and 69. So that's why, like in our old system, we stopped screening at age 70. But you might have stopped screening actually at age 69 or 68 if that was the third pap test for that patient between 60 and 70. In the new system, because we're screening every 5 years, if a 65-year-old has a negative HPV test, in 5 years, they're 70 and they're aged out of the program, okay? So with a negative HPV test between 65 and 70, patients can exit the program. One caveat to that is immunocompromised patients will screen until 74. Okay, so your immunocompromised people who are screening every 3 years are screening until 74. And then patients who are coming back to us from colposcopy and have been advised to rescreen in 2 years will also screen until age 74. Okay, so a negative HPV test between 65 and 70 the patient can exit the program unless they're immunocompromised or unless they're coming back to us from colposcopy. If you do a screen between the ages of 65 and 69 and the patient is HPV positive, you're going to follow the screening pathway. So if they're the highest risk type, they're going to go straight to colposcopy. And if they're between 65 and 69 with an HPV positive with normal or low-grade cytology, you're going to repeat in 2 years. So you're going to follow the screening pathway. And then you'll stop screening when they have a negative HPV result or when they are 74, okay, whichever occurs first. And then the last population of people, so if a patient comes to your office and they are 70, so if they didn't have a cervical screening test between 65 and 69, then they should be screened until 74, okay? So, it's just, in most cases, 93% of the time, it's going to be a one test. So if you see a patient who, I actually saw a patient like this earlier this week, age 70, and hadn't had cervical screening in a long time, we did do a cervical screening test. So we performed their cervical screen, and that when I get that result, if that patient is HPV negative, she can exit the program because she's had her HPV negative. So they're screened until 74, but the next screen would be in 5 years from age 70. So she's now exited the program. Okay. So if they haven't had any screening, between 65 and 69, repeat their screening. If they're HPV negative, that's all they need. They can exit the program. If they're HPV positive, you're going to send them directly to colposcopy. So anyone who's HPV positive over the age of 70 goes directly to colposcopy. Perfect. So that's exactly what I just said. So people age 70 to 74 with an HPV positive result, regardless of the type, regardless of the cell cytology, send them directly to colposcopy because colposcopy is needed to exclude a high-grade lesion. And then people age 75 plus, there is no recommendation for screening patients who are 75 and older. So patients will exit the program at age 74. Having said that, any visible cervical abnormalities. So if you have a patient who presents with symptoms like, postcoital bleeding or new dyspareunia, and you do a speculum exam and you see a visible cervical abnormality, you should be referring this patient to for investigation by colposcopy. Okay. If they're over age 75. So you just send them directly to colposcopy because they need investigation. So vag vault testing, I'll go through this and then I'm going to hand over to Dr. Francis to talk about colposcopy and do some of our FAQs. So this is another important piece for primary care. So vag vault testing, so patients who've had their cervix removed by hysterectomy are they don't have a cervix, so they're not at risk of developing cervical cancer, but they might be at risk of developing a vaginal cancer, depending on what their HPV status was previously, or what their, if they had a cancer, right? So vaginal cancer is HPV related, but it's very, very low in Ontario. So that's why we don't do a lot of, like, we're not recommending ongoing vaginal vault testing anymore, because the incidence of squamous cell vaginal cancers is 0.6 per 100,000 people. Okay, so it's a very low incidence. So we're not needing to do routine vaginal vault testing on patients who have had their cervix removed at the time of hysterectomy, or who have had just had their cervix removed. That's incredibly unusual in Canada, though. Next page. So when you've had a patient, this is important. So when you've had a patient who has had a hysterectomy, it's divided into low risk groups and elevated risk groups. So a patient who had a hysterectomy for non-cancer reasons and have no, so they're and have no history of Julie, why don't you do this? You'll probably do a better job of this than I will. I see you came on. You can
No,
save
I'm
me
just
from this.
anticipating. I'm just like,
You
usually
go
I
ahead.
lock myself off or something.
You do this.
If I can just ask, because I'm not the most tech, am I in control of these slides going back and forth, Sarah, with this little button in the corner?
No, you tell me where you want to go.
Okay. Can we go back one slide in that case? So just to talk about the vaginal cancers for a moment, vaginal cancer is truly a rare cancer, and even within gyne-oncology, where these are the cancers that we see all the time. So anybody who has this would ultimately come to myself or my team or an equivalent in another center. This is our most rare disease site, and we consider it to be a diagnosis of exclusion. So it is much more likely that the patient had a cervical cancer or a vulvar cancer, for example. So it is a very rare cancer. Certainly, if you see something, we would encourage you to send them for further assessment, because we would take biopsies. If it's a gynecologist in the community, like, we would recommend that biopsies be taken. But if the patient has no prior HPV history, there's a relatively low chance that they would ever present with a vaginal cancer. So they've given us some great statistics here, but just to give you a sense of the scope, it is a very unusual cancer. So certainly, if you see something that sends your spidey senses off, please don't ignore that, but at the same time, it's a low risk. So if we can go to the next slide. So when we are talking about patients that we would be concerned about in the post-hysterectomy environment, the ones that we're concerned about are the patients who did have some type of HPV history in the past. The ones we'd be most concerned about would have had high-grade HSIL or AIS. The ones we're less concerned about would have had some type of low-grade or ascus lesion. But certainly, these are the patients that have had HPV in the past that we're concerned about. So historically, taking all comers, we had seen maybe like a 3% recurrence rate in patients who were in the high-grade ASK-H SCC category post-hysterectomy. So even taking the highest risk group of patients, it's a fairly low recurrence rate. But these are the patients that we're concerned about. The ones that had low-grade changes, it's very unlikely that anything would come back. So if we just go to the next slide, I think they're going to we're giving us some guidelines on who we need to be concerned about. So essentially, if people have had one of the high-risk features, so they have had a high-risk HPV type or associated illness, then we would recommend that you do a one-time HPV test 6 to 12 months after the hysterectomy to confirm that they have, in fact, cleared the HPV. If it's a low-risk group, the probability that anything is going to happen is very, very low, so you don't need to do a repeat HPV test in that population. I see that, sorry, if you can go back one more note here, I failed to address the little blue box here, but the patient may be discharged from colposcopy who, if they've done a hysterectomy, for example, for refractory HSIL, and the patient may need to get an HPV test of the vaginal vault if needed. So some of us will bring that patient back and do that assessment ourselves, but other people, depending on the pressures of the situation, may discharge the patient early. So just please be aware that you may be the one who's asked to do the HPV test in 6 months. Next slide. So we have some incredible team here who was able to pull this in so rapidly after my request last night. So one of the questions that we're getting from the community is that it's a little bit confusing how some of the information is being reported out on the Life Labs and the DynaCare requisition. So what we've pulled here is what you might see. So this patient is HPV positive and has been shown as positive for one of the high-risk types. Even though the pap smear itself is ascus, this patient would be referred directly to colposcopy. This is different from what we would have done before, because usually if it had been ascus, we would have told you to repeat that pap smear again in a year. But because this patient has the high-risk HPV type, we can refer directly to colposcopy now. Next slide. So there are 7 colposcopy pathways, and I think that right now, this is also challenging for the colposcopists. I'm not sure how many colposcopists versus family physicians versus general gynecologists we have here. But the 7 colposcopy pathways are a little bit challenging for the colposcopists as well. So I would just ask all of you and all of us to give ourselves a little bit of grace just in this transition phase as people are just normalizing these new 7 pathways. Just there may be the occasional incorrect request, but I don't think that there's anything that's going to go on that will endanger patient care. It may require an additional visit where we didn't realize that we needed one. Most patients will require 1 to 4 colposcopy visits unless they have refractory persistent disease. What these pathways are allowing us to do even now is to discharge patients from colposcopy a lot more promptly than they had been discharged from colposcopy before. Because particularly for the patients that had lower grade lesions, we were keeping them for extended periods of time because we didn't know who was at risk to progress versus who was going to simply be persistent. Now that we have HPV testing, it does allow us to triage those patients a lot more finely. So that does mean that you will be getting patients back that previously would have stayed in colposcopy, and there's a little bit more of a burden on the primary care provider. However, you should get very clear direction from your colposcopist about exactly what needs to happen next. And if you don't feel comfortable with that, please feel free to reach out. Next slide. So I've just put here a triage and some timelines. I have reached out to my colleagues at CCO. We are still waiting for an official CCO guided document about the triaging, but I'm just sharing with you what's being used in the region based on the guidelines that we've received for this. So if somebody has an HPV positive test and they are greater than low grade, so any of the high grade lesions, then we would triage that level as high. So we would try to do colposcopy within 6 to 12 weeks. If we see AIS or AGC, these are the very high risk things that we're concerned about. This is on cytology with or without the HPV testing, really. We're trying to do that within 2 to 4 weeks. If the patient has persistent ALSIL and has HPV positive, but probably one of the other types, then we would try to do that within 3 months. If the cytology is unsatisfactory and it's HPV positive, again, this would be 3 months. If the colpo is negative and the HPV is positive, this is low risk. So we would probably send that patient back out into primary care. And then, as we've discussed with Becky before, that we would repeat the HPV test in a couple of years. Next slide. So when we look at the colposcopy overview, if we look at the little cartoon here, the group that we're really concerned about are the ones that are HPV positive, where we've detected a high-grade histology. So these are the patients where they will still go on to loop or laser, as we have done in the past. And then we will follow up with a post-treatment management protocol and a test of cure. So they will require at least 2 visits before they will be discharged back to primary care. Next slide. But I can tell you, like, since we've had HPV testing, this is the most patients I've ever been able to discharge out of colposcopy. The patients are overjoyed. Like, nobody is sad to leave me. I'm a little hurt by this, but I try not to take it personally. It does require a little bit of a conversation between the colposcopist and the patient, and we really appreciate all of you who are on here who can go on and continue that support. So essentially, the discharge note that you should get should tell you the next interval in screening, so like when we would like you to test the patient next, and what the treatment was in colposcopy, and when you need to send them back to us. I can tell you that certainly the when to send back to us is kind of getting to be a little bit simplified, because if they have a repeat positive HPV on testing after we have sent them back to you, then that would be an indication for re-referral, and that's the primary indication for re-referral. Now, there is a formal document that we are trying to get into EPIC. I don't believe it's in EPIC as yet for those of us who are working in the EPIC environment. However, you should still get a letter back from the colposcopist that identifies these 3 bullet points that we have as check marks here, so that you should feel comfortable with what exactly it is that you are meant to do. Next slide. So just looking for people who were not treated. So these are patients that we saw in colposcopy, but we did not need to do a loop or a laser. We did not need to treat them. So if the referral cytology was low grade, and I was like, you didn't do an HPV test. What do you mean? Oh, and we had an HPV positive test, right? So we saw the patient, it was normal or low grade. We saw the patient, we looked at it colposcopically. We did not see a colposcopic lesion of concern, and or biopsies taken at that time were negative. Then the patient, after a single visit, can be discharged back into the community for a repeat screen in 2 years. If that screening is negative at that time, then that patient can go back to regular treatment. So they'll be as if none of this ever happened, and they'll be rescanned again in 5 years. If they're HPV positive, then they're coming back to colposcopy. For the patients that the referral cytology was high grade, then those patients, we would repeat the HPV test at the time of assessment in colposcopy. If the HPV is negative at that time, then we are returning them back to the community, and the repeat testing would be in 5 years because we are HPV negative. If they're HPV positive, but we did not see anything, so colposcopically the patient is clear, however, we have a positive HPV test, then that patient would be rescreened in 2 years. And in 2 years, if they are HPV negative, then we can go back to the regular screening. If they are HPV positive, they are coming back to colposcopy. So the takeaway from this entire slide, and I'll emphasize it again at the end, is if they are HPV negative on rescreen in 2 years, it's as if this never happened. If they are HPV positive, they need to go back to colposcopy. That was a lot of talking for me to just get to the point. Negative, go on as usual. Positive, back to colposcopy. Okay, next slide. So these are people who were treated in colposcopy. So we had to do a loop, we had to do a laser. If everything is negative at the top, then presumably we're going back to normal. At the post-treatment visit here, if we're HPV negative at the post-treatment, good. We're HPV positive at the post-treatment, then that patient may still be discharged if we can't see anything, but they have to be rescreened in 2 years. If at the 2-year rescreening, they are negative, then we would rescreen again in 2 years because this is a slightly higher risk group. So as opposed to going back to completely normal, they need to be screened and then rescreened. And then if they're negative, they can be going back to regular protocols. If they come back positive, then you can skip all of that because they're coming straight back to colposcopy. Okay. Next slide. Okay, so now we get back to, this is on the colposcopy side, so it's not too alarming for you, but if we have HPV positive at the time of our first visit and HPV positive at the time of discharge, then they need to be rescreened in 2 years, and if they're negative, rescreened in 2 years, and then if they're negative, return to regular. If they are rescreened in 2 years and they're positive, back to colposcopy. Same thing on the next slide, positive, back to colposcopy. If they are positive at the first visit and negative at the second visit, then this is a slightly lower risk group. So we would rescreen in 2 years, and if they're negative, they can return to the usual protocol. Next slide. AIS, I would say, is probably the group of patients that we worry about the most. And the AIS, I'm sure most of you are aware, but I'll just state for purposes here, most of the things we see on the cervix are squamous cell carcinomas. Like if you get a cancer, it's a squamous cell carcinoma because most of your vagina and your cervix is made of squamous cells. However, within the endocervical canal, we have glandular cells. Those glandular cells track up and meet up with the endometrial lining that gets shed, as you guys know, and those are glandular cells. The difference is that squamous cells are flat and they're continuous. Glandular cells follow all sorts of tortuous patterns. So because of that, we are always more concerned that we've missed something, or worse, that it has tracked up into the canal and up into the uterus. So because of this, if you see AIS and or AGC, we are a little bit more animated than we are with the squamous cell lesions because we have a lot more control of what goes on with the squamous cell lesions, and the glandular lesions are a little bit easier to get away from you. So we do tend to be a little bit more rigid in our management. So if you look at what we're doing with these patients that had AIS, so regardless of the post-treatment HPV result, right? Because we're a little bit more uptight here. If they're HPV negative at discharge, then you're going to rescreen in 2 years. HPV negative, rescreen in 2 years. HPV negative, rescreen in 2 years. HPV negative, return to risk. Okay. So there's just a lot more following of these patients. And if anywhere along that pathway you get a positive cytology, we're referring back to colposcopy. So I hope that that additional background just helps you understand why we're a little bit more vigilant with these patients. So they need to be followed for a longer period of time before we would return them to the regular risk level. Next slide. So here we're just looking at like sort of a bigger overview of post-discharge screening. So most people who are discharged from colposcopy, the vast majority of your patients are going to be able to return to the average risk screening in 5 years. For the moderate risk people, we will be doing HPV testing again in 2 years. And if they're positive, they're coming back to colposcopy. If they're negative, then they can go back to their regular risk as things were normal. And for the ones that are higher risk, rescreen in 2 years. Again, if positive, if negative, repeat again, and until you get everybody down to the average risk, or they're back in colposcopy and we will reassess them at that level. So I think that we're just trying to emphasize the point. So the majority of people who are discharged from colposcopy will be returning to average risk screening in 5 years. If they are immunocompromised, and Becky did a great job of reviewing the categorization of people who fall into the immunocompromised categories. We know that there are several of those. Those people will be rescreened in 3 years, and then the moderate risk patients in 2 years. You should have a clear indication from the colposcopist which one of the categories the colposcopist feels your patient will be following up in, and you should have a clear indication from the colposcopist about what exactly the management plan of the patient would be. I can tell you that in our region, most patients with AIS will have been seen by a gynae-oncologist and will give you very clear instructions on what to do. Next slide. The other issue is that for the lower risk patients, they may only be seen in colposcopy 1 time, and they may still be HPV positive at the time of discharge. However, if that happens, there'll be clear instructions to you on how that patient needs to be followed. And if they come back as positive, we sent them to you positive and they did not clear it in 2 years, then all of those patients are coming back to colposcopy. And again, if there are any questions about any of that, please feel free to reach out. Next slide. So there were just a couple of, like, as we know, it's a new system, so there's always a couple of little tweaks. So there was a little bit of an issue with the HPV recall letter campaign. I myself have encountered quite a few patients that fell into this category. No doubt you have as well. So they're patients who were between the ages of 69 and 74 that already got a letter telling them, you're good here, you're good to go, got a letter telling them to come in and get their HPV test. This issue, like on a logistics level, has been resolved, but there will probably be still questions from patients that got a letter from the government telling them to come in and get their HPV test. If they have previously been cleared under the old system, they do not need to come in and get an HPV test. I will tell you just like my own experiences, there's a subset of patients now that they got the letter telling them something, they just don't have peace of mind. So I have done some HPV testing and told them that they may be charged for this because like they technically didn't really need to be retested. And I don't believe anyone has been charged as yet, but I do tell them that they may be charged for this because it's really unnecessary to retest a 72-year-old that's had 3 negative pap smears between the ages of 60 and 70. One of the other questions that I've had a few times that we've just raised here is if the patient was supposed to have a pap smear in 2026, do we do the HPV testing now? The answer to that is no. We would do it in 2026 when their next pap smear would have been due. However, if they have symptoms, I never disregard symptoms. But if the patient is asymptomatic and they're well, and their next pap smear was not due for a year, you would not repeat it now, you would repeat it in 2026. If you have an unsatisfactory test result, you can choose the cytology test only. You don't need to repeat the HPV test. And there have been some instances of the lab reports not coming out entirely as the one we just saw, where there's been some confusion. If you have any confusion about investigations that you're looking at, please reach out to me because I am escalating these just while we try to get Life Labs and DynaCare to have systematic testing so that we can all be clear on what it is that we're supposed to do. So if you do get a test that you're not sure about, please reach out to me and scan and send a copy of the test so that we can share that with CCO and get these things clarified. Next slide. So incorrect requisition used, missing or incomplete test indication. So I don't know about all of you, but we're just not perfect here. So we've had a few episodes. So the main thing is that we've experienced, I can't speak to everyone who might be on this training session, is whether you're using the colposcopy requisitions versus the cervical screening requisitions. For those of you who are in primary care, you probably don't even have the colposcopy requisitions at your office. And if you do, my advice is to burn them or something, because if you send out the colposcopy rec and you were really trying to do a screening thing, it creates a lot of drama. So the primary thing is to make sure that you're on the correct requisition at the time that you write it. Please be on the screening if you're screening in the community. And for those of us who are colposcopists, please be on the colposcopy form if you are doing colposcopy. So they are sometimes not able to confirm this information with the provider. So one of the things we've learned, for example, if you were trying to do a screening test and you filled it out on the colposcopy form and you are not a colposcopist, they will not let you correct that. You will need to find a friendly colposcopist to sign off your forms for you or redo the test. Contact your lab as soon as possible if you're aware that it's just missing information or something like that. A lot of those can be corrected. And make sure that you're using the new OCSP forms. My advice is don't have the colpo ones in your office. If you leave the collection device in the vial, so I'm sure we're all aware now, don't put it in the vial. They will just give you some information about how not to do that, but just basically don't do that. I have colleagues that have sent a month's worth of specimens in the vial. So if you've done that, you're not alone. It's okay. We'll recover. It's not clear to me if they're actually still sending out the test. You may be asked to recollect the specimen. That's okay if you have to. Not a problem. Next slide. So what do we do for patients that are symptomatic at the time of screening, that are due for screening? So if they're due for screening, we can go ahead and screen them. But also, if you have very concerning patients, please feel free to send them to colposcopy. We will triage them. If you have patients that are symptomatic that are not due for screening, I think this depends a little bit if you're a gynecologist versus not a gynecologist. If you are a gynecologist, I would recommend, if you feel capable, you can take some biopsies. If you're in primary care, you can describe the situation thoroughly and send it to colposcopy for triage. When to refer to gynecology versus colposcopy for abnormal bleeding. What I would say is if it's cyclical bleeding, so it's associated with their menstrual cycle, I would lean towards gynecology. But if it's postcoital bleeding, that is more towards colposcopy. I'll repeat that one more time. If it's cyclical bleeding, so it's associated with their menstrual cycle, I would lean towards gynecology. If it is postcoital bleeding, I would lean towards colposcopy. Next slide. Okay. Are there any questions?
We do have two. Sorry, go ahead, Becky.
I was just going to say, there's a couple questions in the Q&A.
How come I can't see any? I've got blank.
So the first question is, I have a never sexually active patient. So this is from Kathy. I have a never sexually active patient who's had a stem cell transplant. They, so presumably the oncology team, have recommended she have cervical screening. Should she be screened if she's never had any sexual contact?
Sorry, the oncology team that said this were the hematologist, I'm assuming?
You got it. Yeah.
Okay.
Yeah.
And there's never been any sexual contact at all?
Yeah, so that's what the question is, never sexually active. So I mean, I guess what I would suggest to you, Kathy, is, and we'll let Dr. Francis add to this, I would suggest clarifying sexual activity with your patients. So sexual activity includes any touching of any of the sexual parts, right? So vaginal touching, kissing, it's not just penetrative intercourse, so, or receptive intercourse. So I think that's the first piece, is clarifying what sexual activity actually means. And if the patient truly has never had any sexual activity, I would imagine Dr. Francis would agree, this patient doesn't need to be screened. But if the patient has had any sexual touching, kissing, anything that qualifies sexual activity, this patient does need to be screened. Yeah, you agree with that, Julie?
I 100% agree with that. I'm pondering so what I would say is, if that patient really does need to be examined, because particularly in these stem cell transplant patients, they can have graft versus host disease, and they can have terrible pain in their vagina. So if you did feel that you needed to do the testing, and there were a lot of concerns about that, you may want to ask someone who has it doesn't need to be a gynecologist, but somebody who does a lot of pap smears so that they have a wide variety of speculum sizes in their office. This may be somebody who requires a pediatric speculum.
Perfect. The second question is, a patient younger than 25 wants to have HPV testing. This patient is asymptomatic. Can the patient pay for HPV testing? And what form should we use in this case?
I cannot see why they could not pay. I believe that they would have to use that federal form that is outside of the screening program, because they wouldn't meet screening criteria. It would be outside of the screening program, certainly.
Okay. And I would say, I would agree. If the patient, so I would suggest that as a primary care physician, they actually talk to your patients about screening under the age of 25. So one of the reasons that we don't screen under the age of 25 is that young people have very robust immune systems, and young people are very likely to clear HPV infection. And screening and detecting HPV infection under the age of 25 can actually put patients into that colposcopy chain, right? It can lead to unnecessary testing. It can lead to unnecessary anxiety, and it wasn't necessary, because that patient will clear their HPV anyway. So 90% of HPV will be cleared within 3 years, just so you know, of all HPV, and 95% of all HPV will be cleared within 5 years. And it's really those cases that are persisting or that are high risk that we're really trying to identify. So I think the first thing is actually educating your patient about that screening is really unnecessary under the age of 25 for those reasons. Really robust immune system, very likely to clear this infection anyway. And if the patient does choose to proceed with testing, then exactly as Dr. Francis said, using that, you'd have to use the non-OCSP form, and it will be a private pay. The patient will actually get a bill from the lab.
To further on that, though, those types of investigations do put us in awkward position, because you may want to emphasize with the patient, they may now find themselves in a situation where they've tested HPV positive, but they're not going to pass the triaging protocols. So there really wouldn't be anything that we could do in the absence of a primary care provider having looked at their cervix and having concerns, right? So if the primary care provider looked at their cervix, patient of any age, and there were concerns, and certainly if that was associated with a high-risk HPV type, we would agree to see that patient. But if it's a totally normal looking cervix in the view of the family physician, and there's an HPV positive test, that patient wouldn't meet criteria to be seen in colposcopy. So they may be creating some unnecessary anxiety for themselves.
Perfect.
But I would say that.
Thanks, Julie. There's another question just asking for a clarification. So can we review one more time? So age 65 to 69 needing screening versus not needing screening because the letter they received was a mistake.
Okay, so if you guys remember the old system, if we had 3 negative pap smears between 60 and 70, basically, then we were not triaging those patients anymore, right? So like you don't need to be tested again. So if you were tested at 62, at 65, and at 68, and it was negative, 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 then the old system said you're good to go. So what we missed is that then there were people who were negative, negative, negative like that, but then still got a letter telling them to come in and get their HPV test because they're 68 and they're under 70 and they haven't been HPV tested. So if you would have said that that patient was okay under the old system, they are still okay. They don't need to come back for HPV testing, even though they got the letter. If they hadn't completed their procedure, like if they had done 2 and not 3, then they can come back in and get their HPV test. Like they can do that. It's just that because the HPV testing lasts longer and it's 5 years, if, as Becky said, they came in at 65, you don't need to bring them back again at 70 because they did the 65-year-old one and then they'll have aged out at 70. So essentially, if you would have said they were okay before, they still are. They don't need to come back in and do an additional HPV test. If they were good to go, they're good to go. You may not be able to convince them of this now that they got the letter. That's where I'm failing as a provider because now the government told them that they need the test. But I can tell you on a clinical evidence level that if they were good to go, they're good to go.
Thanks, Julie. I find most of my 72-year-old women are quite happy for me to tell them, no, you don't need another speculum exam. There's a bit of confusion around the sexual touching, so we just wanted to clarify that. So sexual activity is defined as any sexual contact with another person's genitals, private parts, okay? So this contact can be with the hands, the mouth, or the genitals, and includes the sharing of sex toys. So it's not kissing on the lips, it's kissing the genitals, okay? So I apologize if there was confusion about that. So sexual activity, any sexual contact with another person's genitals, the contact can be with the hands, mouth, or genitals and includes the sharing of sex toys. So I think that's just important so that we understand that we're helping our patients when we're deciding if they're needing screening at age 25. So anyone who's ever had any sexual contact, even if it's been a long time ago, they're still due for screening. Okay. And that's whether it's with person of same sex or alternate sex. Okay. So if you have a cervix and you've ever had sexual contact and you're over age 25, then you're due for screening. There's another question for you, Julie, to confirm for patients with previous abnormal cytology. So just to confirm, for patients with previous abnormal cytology results having follow-up with the new HPV testing algorithm, do we just follow the standard algorithm based on the HPV cytology results for further care?
So I'm just going to clarify and make sure that I understand what you're asking. So let's say your patient had ascus last year, and now you would have normally repeated to do another cytology this year, right?
Correct. Yeah.
You are going to do the HPV plus cytology screening this year, and we are going to manage that patient based on the results of that newest test.
Perfect.
Which may be that it is ascus, say, and HPV negative, right?
Right.
So if it's ascus and HPV negative, your patient is probably 55 and we're not worried and she can be tested again in 5 years.
Right. Yeah, and in primary care, we won't even find out if they're ascus HPV negative because if they're HPV negative, they won't have the cell cytology. Right. So it's less confusing for us in primary care now because we don't have to manage all of that. That's fabulous. I don't see any other questions in the chat, and it's 8:32. So I think we will let everyone get to their clinical days. I just want to say a huge thank you to Julie for bailing me out of the what to do post-hysterectomy. Thank you. That was fabulous. But you guys can see, like, this is like, we all have questions, right? We all, like Dr. Francis said, we all have used the wrong requisition, have left a broom in the sample. We're all learning together. If you have any questions, reach out to us. We have a really fabulous team, and they will forward the questions to us. If we don't know the answer, we'll try to find it for you. And if you're having challenges with there is a challenge for sure with the way TELUS is importing the HRM results for HPV testing, or cervical screening. So we're working on that with TELUS. I think it's actually probably an update that's needed at TELUS. So we're working on some of this background stuff with just the way lab reports are imported. But please send us your challenges so that we can help resolve them.
Great. Thank you so much, Becky and Julie. Just want to say thank you for your time this morning, and thanks again to everyone for joining us for this really great information. I hope everyone has a fantastic day. Take care.
Bye, guys.